afternoon, hello and welcome. Today I am delighted to be joined by Dr. Sarah Rollins, who's a sports and exercise medicine consultant. Sarah, how you doing?
Yeah, good, thanks. Hi, it's good to see you, Andy.
Likewise. So I know since we last met at Pure Sports Med that you've been off on your travels and you've recently got back. So what have you been up to?
I've been wandering around in Scandinavia, going to various orienteering competitions. So running through the forests of Scandinavia. Yeah.
So I mean, I did orienteering when I was back in the Cubs Scouts and all that. I actually used to love it, but like I didn't really know it was a big thing. And having looked into your background from the times that we've spoken and from speaking to the other consultants that I've met and have mentioned that we've chatted and things, and they've been quite uh well impressed and amazed by the stuff that you do with that. So just tell me a bit more about what it involves.
So orienteering, it's a bit of a naff name, really, but we haven't really come up with a better name. I suppose wild running or but it's a race. It's not just going out with maps and cagoule and woolly hats on. So it's a full-on running race, but instead of the course being designed for you, you have to visit a variety of checkpoints as quickly as possible, but there is no course, so you have to find your way there. So orienteering as a discipline is it has a variety of formats, but the longest course is a roughly 70 to 80-minute winning time. And it all depends on the terrain as to how far you might go. So if it's really rugged, hilly terrain, then you might only run something like 11 to 15K, depending if you're a man or a woman. If it's sorry, that would be if it's relatively fast terrain. I mean, they've just come back. The European champs have just been in Hungary, and so the men were running 15 kilometers, but their actual distance ranged between 17 and 20 kilometers because, of course, you don't actually run straight line. You choose your own route, which might include going straight through the forest, or it might include going out to a track and running round. But the point is that you have to find these point features in terrain, and there are special maps so that show you how fast it is to run. So the maps are drawn at 1 to 10,000, and lots of things will be on the map, and they show you this is a runnable bit of forest, so that would be drawn in white, or it's getting slowly greener, so slower, and it'll be marked so that you can make a choice according to the map as where you want to go. It's
Yeah.
massive in Scandinavia and Switzerland. So I went to a competition in July in Sweden, and there were in excess of 15,000 competitors at this competition called O-Ringen. And it's just honestly, if you're a runner and you like running in the outdoors, it is extremely good fun because you are running through terrain, choosing your own routes, ducking under things, jumping over things, getting completely covered in scratches and mud, and obviously racing is competitive. So, I mean, I quite like it, as you can probably tell. Yeah.
Yeah, no, it's really interesting then. So, I mean, when I love walking and hiking and getting out there, and you see fell runners, and I'm always like, it's so impressive because it's so hard. It's hard work walking up a lot of these places. Then you've got people running or jogging them, and then from yours, you're adding in an extra bit of actual navigation and working out actually where you're meant to be going to it as well. So it must be it's quite a mental thing as well, I guess.
Yeah, absolutely. So, I mean, we always say that you should probably only run as fast as you can navigate. And it's walking that fine line between running as hard as you can, whilst also still trying to work out where you are, or at least where you're going on the map. And so it's quite a good psychological game as well, where you're trying to not go into too much oxygen debt, because otherwise you start making stupid decisions, might, for example, miss out control, or yeah. And so but the bottom line is you're running hard. This is a cross country race. You're not walking anywhere. Having said that, when you first start, you may need to walk because you might not be able to do the navigation at speed, and it takes time to learn. And the sport is completely accessible for all. Kids they start with little string courses when they can walk. And So they'll follow a bit of string and terrain, and they'll have a little paper map that they use. And then, but it's accessible, and then it's accessible obviously to elite athletes. So there's an international circuit, and then it goes all the way up to however old you want to go. So I was in Finland at the World Masters in August, and the oldest category was M and W 95, and they're still staggering around the forest. Get a standing ovation when they appear alive at the finish line. And it's incredible that they're still, and obviously in Scandinavia as well, some extremely fit competitors. So it's great. And what I particularly like it is that you can do it as a whole family as well, not together, but what I mean is you go to an event, and so I'm competing in my age category, and my son's competing in his. And in fact, my son's made the Junior World Champs team this year, and he's spent essentially the entire summer away training and racing orienteering. He's been in Czech, Poland, Sweden, Finland, and he's back in Sweden again now on a training camp, and just having some really great opportunities. So yeah, so I think it's fantastic sport.
Yeah, it must be so good. Again, the physical side definitely is going to be helpful, but then that constantly thinking and working on things. So just to clarify as well, is that like so you do it on your own then rather than in pairs or a
Yes,
team?
so there's only one event that's a mass start, so that's a relay event. So the first leg for each team will go out. So let's say you were at the European Champs. There'll be one British team, for example. In fact, it doesn't quite work like that, but nevertheless, there'll be a team from Great Britain, Sweden, Finland, etc. And all the first leg runners out of three will go off together. But by the time you get to second and third leg, it might have broken up because some people might have made mistakes. But usually it's a time trial. So everybody starts at like 2 minute intervals. You will see people in the forest because if they've made a mistake or you're running faster than them, you'll catch them up. But generally, it's supposed to be you're on your own, you choose your own route, and and so everyone will start between the times of like let's say 10 and 12, and it's not until the last person finishes that you find out who's done the fastest time.
Mm,
Um, yeah.
yeah.
I was going to say something. I can't remember what I was going to say, but uh, obviously it means that because it's a time trial, it means that families can attend and everyone gets to have a go because the mother can run, for example, and then the father can run at the end. And so it means that there are lots of orienteering families who go to events together. And so again, that's another reason why it's a really cool sport for like doing stuff, with your family. And it's not, like with football, for example, it's not like you might have your family supporting you, but they don't watch a game and then say, right, we're having a go now. That would be slightly unusual. Yeah. So,
Yeah, no, it's really interesting. I mean, I could talk about this for ages because it does sound really interesting. Like, and it's again, I like getting out, and I think it's a great way to be in the environment whilst also doing something competitive and mentally challenging as well.
oh, that's what
So
I was
yeah,
going to say. Sorry, just very quickly on that. Strangely, there was a study that's been done, I think it's from Canada, that showed that orienteering is a very good sport, not only because it keeps you active, but because so the cognitive side is linked with reducing the incidence of dementia. So, and that actually came out of a scientific study. So, yeah, anyway,
yeah,
just
no,
as an
well,
aside,
it's
yeah.
is it has there been any talks of Olympic
I think
inclusion?
the International Orienteering Federation have been trying for years to try and get it into the Olympics. It was going to appear at the Commonwealth Games, which I think were going to be held at one point. Was it in Australia? But I'm not sure whether that's now going to happen, in which
Right.
case, or whether they went with something else. I've kind of lost track. But I kind of, it's so exciting to watch. So they now put it on TV. All of the international events are televised, and I spent the weekend last weekend watching the European champs. And it's good when the commentators are taking you through what's going on. But I think it's brilliant sport. It's a bit like watching downhill mountain biking. Um, you know, um, and although as a time trial, let's say, yeah, I suppose that's a time trial. You can't all be on the course at the same time. But it's about watching people go down through a course. And now with drone technology and with tracking devices, you see where they are. You can watch people making mistakes. You can see people in the forest. Yeah, it's really fun.
Yeah, good. No, I can definitely see a passion in it. I like it.
Yeah,
We did a Pretty Mudder as a company recently, so that might be a couple of rungs up from that one. But it was good fun, and it was good
cool.
for a good cause. So yeah, thank you for sharing that because it is really interesting. And like for you, so where are you from originally, and like where are you based now?
So, well, I grew up in Germany, and so I don't sort of really feel like I come from anywhere in the UK, but I guess I grew up in the south of England, and I still live there now. So I live down near Guildford, yeah, and I work in Aldershot for the MOD, and I work for Pure Sports Medicine in Rains Park. So I live close enough to get to both of those.
So how the German was that a military link then that you
No,
grew
my
up?
dad just had a job that happened to be in Munich, and so I grew up in Munich, which, well, just outside. So I grew up with, with snow and sunshine and lakes and mountains and skiing and cross-country skiing. So lots of outdoor stuff. But I didn't start orienteering till I was 19 when I joined the Officer Training Corps when I was at university. So I did lots of outdoor stuff, but I just wish I could have started orienteering earlier because it's so much fun. But yeah, always enjoyed being active. And I was already running before I started orienteering. So I was doing, running for fun, but also I just done the London Marathon. I think that was age 19. So I was a keen runner, and I've always been a keen runner, even going back to like my primary school. I already knew that I enjoyed running.
Right. And then so when you in Germany then, at what age do you move back to the UK?
I think it was about, I was around about age 13 or 14, we moved back.
So you
Yeah.
fully German sounding then? Like what was your accent like at that point?
Well, if I spoke German before the age of 14, I would speak with a good German accent, albeit from Bavaria. And then you kind of, lose touch a little bit. I did A-level German. I do speak good German, but I haven't used it properly. I haven't gone back there enough. So I can understand it really well. I can read it completely fine, but I have word finding difficulties. I'd be talking to someone and then go, I'll just put the English word in because I think I just can't bring that back. I'm sure if I spent any length of time there, it would just come back. Yeah.
Hmm. I spent some very fun times in the Hofbrauhaus in the 2006 World Cup in Germany, but that
Yeah.
was
I was a
that
bit
was yeah.
young to enjoy that at the time. Yeah.
Yeah, no, it's a great country, Germany. I think it's a really, really
Yeah.
cool place. Doesn't always get as much, like people don't seem to go on holiday to Germany for some reason, but it's a great place to go.
Yeah, yeah, some absolutely lovely bits. I mean, I'm biased for Bavaria, but there's absolutely beautiful bits. And orienteering has taken me also over into the sort of what used to be Eastern Germany side as well. And so I've done some running in now what mountains are they called? Um, I think they're called the something Alps. I've forgotten what they're called, but I've run in those mountains as well. So yeah, some beautiful bits, beautiful bits.
Yeah. So when you moved back then to the UK and you were like before going into university, like what made you want to go into medicine?
Well, I'd love to say that I'd always wanted to be a doctor, and it was a calling. But what actually happened was I was in a room next door to another girl at school, and I was filling out my UCAS form, my university form, application form, and I thought I have no idea what I want to do. And I walked into her room and said, "What are you doing?" And she said, "Oh, I'm applying for medicine." And I was like, oh my God, that's what I want to do. And so I walked back in and applied to medicine. And it just so happened because I love science, I'd done the science subjects. So I was able I had what needed to apply. I don't know, I just hadn't really given anything enough thought. Maybe that was a bit young or naive, I don't know, or maybe lack of guidance. But when I heard her say that's what she was doing, I was like, well, that is totally what I want to do. Because I love I love biology. I love science. I now love anatomy, and that all like fell out of, or I when I saw what was in the course for medicine, I just realized that that was the right one for me.
Yeah. Yeah, so you'd gone down that sciencey route already. And then did you mention that you'd gone into the core at 19?
Yeah, so I did. So while you're at uni, you can do reserves, and so I did officer training corps while I was at university. So I basically joined the reserves at age 19 and did 3 years as an officer cadet whilst I was at university. And then I actually, because I decided at that point, having done those 3 years, that I wanted to have an army career. I then applied for a cadetship. So for my last 3 years of university, I then had I became a second lieutenant, and I was sponsored by the military with a view to then immediately joining the army on qualification.
Right. So then, for like within that, like what was your ambitions at that point then?
Well, once I'd started orienteering, my main ambitions were probably sport. And certainly in my early doctor and army career, I would choose things on the basis of whether it would allow me to do sport. Because I think so I'm trying to remember the actual, so I started orienteering at 19 in 2000, so I would have been 26 or 20, well, I can't remember basically. I can't do maths. 24, I made the World Cup team. So um, and that was the year before I qualified as in medicine. So I'd got into the GB team, and so everything I did after that was about I want to train, I want to race, I want to compete for Great Britain, and so I just tried to make choices that allowed me to do that.
Yeah.
Yeah.
Yeah, and so was that all encouraged then? I know that like so I've know played football with some people in the military and like they were just professional athletes basically, just what happened with football or whatever it is that they were doing.
Yeah, so orienteering isn't actually a military sport. It's counted as military training. So in some ways that's good, and some ways that's not good. So the good way is that when I was, doing officer training corps, if you go on an orienteering training camp or a racing camp, you get paid for every day you attend. So we used to go on the 6 day um, uh, racing sort of camps, and for every day we were there, we would be paid, and all the accommodations paid. And but at the same time, because it's not a sport, you don't then get that elite athlete status as a sport. And So I was never a full-time athlete. I did manage to persuade during my GP training. I did manage to persuade them that I could do 50%. So over a course of 1 year, I did 6 months work, which allowed me then to a bit more time to compete because it was quite difficult fitting everything in around also qualifying as a general practitioner, which was my first speciality. But essentially for orienteering, what you need to be is you need to be a fast runner, and then you need to apply that in the forest. And so most of the training you can do around a job. Now it's a little bit more challenging when that job includes nights and weekend work, but nevertheless, for the most part, you can, most people with a normal job would be able to fit in their running club, their interval sessions, their hill sessions, their long runs around a normal working week, relatively speaking. It's when you want to go on training camps, it's more difficult because in orienteering, of course, it's very different what terrain you're in as to how you run. And so if you're going to go and race in Japan, you need to go to Japan and you need to train in those forests. Otherwise, you're not going to be fully prepared. So it was those kind of things that I needed to do, which I had to just be a little bit imaginative about my annual leave and so on, and asking for time to be able to go and do that sort of stuff.
Does sound like a great setup in the military. Like you're learning all this stuff and you're essentially getting paid to be doing the stuff that you love doing.
Yeah, although I mean in the military you're paid 365 days a year, 24 hours a day, and then whatever you get asked to do, you get asked to do during that time. And yeah,
Right.
you get a normal amount of annual leave. So I think you get 6 weeks leave. But then you can have leave for, and this is where the whole it's not a sport thing comes in because it's military training. So you wouldn't have to take annual leave to do military training. And so I was also given opportunities to do orienteering as military training rather than taking my leave away. I mean, obviously, all my leave got used for racing anyway, but it meant that there was a little bit of slack in the system. But bearing in mind that you also have to satisfy the needs of your training. So, if you're doing emergency department training, you're doing A&E, you can't just say, well, I'll see you later, guys, I'm off for 2 months. So it's always been a bit of a juggle. And to be honest, I probably never achieved what I really would have liked to have achieved in orienteering because I wasn't able to make that next step because I decided to carry on with my military and medical career really, to be an elite athlete, you need to stop and give it everything. And I didn't do that. And in hindsight, that was probably a good thing. I wouldn't be where I am now if I hadn't, if I'd done that. But I didn't quite achieve what I wanted to achieve. So I never medaled at the World Champs. I got ninth in the World Champs. I got an eight in the World Cup. I've been on the podium, which includes the top six in orienteering, in relays. And I got a world university champs gold medal in the relay as well. But I never quite made the next step, which is what I would have liked to have done. And that was, in my opinion, that was just running speed. I just couldn't run as fast because I didn't have probably enough sleep. Um, and I was trying to juggle both, medical training with also racing, and just that combination. I was doing lots of training, but I was probably a little bit overtrained, overreached, maybe a bit stressed, which is, if you're going to be a proper elite athlete, you need time to eat, sleep, rest, and race, and yeah. So it is what it is, but I'm very glad where I am now. But I look back and think, oh, could have just been that bit better. But then, you make those choices and you have to live with those choices. So yeah.
Yeah, well, as you say, it's worked out pretty well in terms of what you're
Yeah.
doing. And, like how impactful and how helpful is it basically being an elite athlete and doing that the cross country running, the orienteering, all of that in terms of helping the medical training and your just knowledge in general.
Well, I think, if you've been heavily involved in sports teams and you haven't been an elite athlete, you can still do the job extremely well. I don't think you have to have been an elite athlete, but I suppose it does give you that personal experience. I would like to say that probably one of the biggest things is I dabbled in most tendinopathies myself. So I know what it is to struggle with a whole host of tendinopathies around the body. And I'm probably an elite Achilles tendon patient. What I mean by that is that I've been both the worst and best patient for someone with Achilles tendinopathy. So when I'm managing people with tendinopathies, I feel like I have a lot of insight into the psychology of those kind of injuries. So yeah, it definitely has an impact on how I manage my patients, because I understand the frustrations of injury. And I'm sure that, many doctors do the same. But for me, that I feel like I've got that insight.
Yeah. And then so when you were at the military, then where were you being placed? Like where was your main base? Were you going on different tours and things?
So I was actually talking to someone about this morning. So I did 10 year, no, 11 years in the army, but of those, three of them were my cadetship. So I was still training to be a doctor. And then once I qualified, I dropped into this group where they were trying to push us through GP training as quickly as possible. And it was a really weird time. So now it's completely different. And so you qualify and you do your junior doctor jobs, and then you go off and do something called General Duties Medical Officer. So you basically mark time for 2 years and you go and do army stuff. So you go off and you go on exercise and you experience what it is to be in the field and be looking after soldiers in, foreign countries on exercise, on operations. In the year that I joined, they decided that they needed more GPs as quickly as possible. And they decided to shove us through training without doing GDMO, this General Duties Medical Officer training. So I went straight from I basically lost no time. I didn't have that 2 years. So I went straight from doing my house officer jobs to doing my emergency medicine job, because that was the other thing they decided. They decided that all army doctors had to do A&E. And so I went and did that. And then they said, right, straight into GP training. So I went straight into doing that. And then so I qualified in 2001. By 2006, I was a qualified GP. And that was including 6 months of, I said, I did 12 months work over 6 months. 6 months work over 12 months. Yeah. So I was half a year delayed compared to the other cohort of GPs in my group. So I got to the end of my training really quick. Um, And then in my GP jobs, my first one was at Sandhurst, which is the Officer Training College Academy. And that is a non-deployable post. So you go there and you look after the officer cadets who are in the UK training. And then so that was for, can't remember now. So that was that. Then I went and did the Joint CBRN Regiment, which is Chemical, Biological, Radiological and Nuclear Regiment, which was at RAF Honington. I was at 3-2 Regiment Royal Artillery, which is they fly unmanned drone aircraft, so they don't deploy as a unit as well. So I did lots of cool stuff, but I didn't get deployed overseas because of, number one, that rapid rush through GP training. And then after that, because we were between kind of episodes of conflict, and so there wasn't really anything going on. Then I had my son, and so was non-deployable for a year. And then there was a slight, that's when I decided to leave the army, because there were some issues around what the army wanted me to do and what I wanted to do as a mum. And so I decided the best thing was for me to leave, because psychologically I wasn't ready to leave my son for periods of 6 to 9 months in the UK while I was away. So I'd already signed off all the paperwork to move to Headley Court, which is the tertiary rehab facility that's now moved to Stamford Hall. But the GP Carder decided they wanted me to go to Canada for 6 months, which was fine. I was still breastfeeding my son, and they said, no, it's fine. It's an accompanied post, which means you can go with your family. And then I phoned the doctor who was out there and said, oh, I'm due to come, I'm bringing my son. And they said, no, this is on the plains. It's not an accompanied post. You can't bring your child. And I was like, right, that's it. I'm out, because I couldn't at the time, and probably even still now, I couldn't compromise on what I wanted to be as a mum. So I decided to leave, which in hindsight was the right decision for me. It's a shame because, it would have been amazing to go to Headley Court. I would have gone straight into sports and exercise medicine training. And I think I worked out the other day that decision as a mum, to not stay in cost me 8 years. I lost 8 years of being a consultant, as it were. It took me that long to catch up with the career that I would have had if I'd sort of taken the other path. But got there in the end, and done a lot of cool stuff in the meantime. So it's all worked out.
So what did you do then when that fell through, or you decided not to do that post?
Yeah. So obviously I left the army and became a civilian doctor working for the MOD, which was kind of like an easy way to slot into stuff that I already knew. So I was a GP working for the army as a civil servant, and I still do that now, except that I don't do it as a GP anymore. I do it as a consultant in sports medicine. And initially I was doing that part-time, which allowed me then to do my sports, and also allowed me to be a present mum, and to also continue my medical career working for the armed forces. So I guess in some respects it kind of worked out anyway, and was the right decision for me.
Yeah, and then can you just explain the difference between being, civilian and not being civilian? Because again, I've dealt with the military off and on over the last 20 odd years, but it's still, I think it's interesting for people who aren't that closely linked to it.
Yeah, so the military employs serving officers, doctors, and physios, for example, and they would be in uniform. So they're trained. They have to do their mandatory military training every year, and they are deployable. So they can go away on exercise and to war zones, so on operations. And they are on a separate wage because they take what's called the X factor. So they're paid for the risks that they take and the fact that they're available to work 365 days a year, 24 hours a day. And then, of course, there are those who work for the military, but who are civil servants. So you are a qualified doctor or physio or whatever, but you are employed in one role. You don't move around. So the military usually move every 2 to 3 years to a new job. Whereas in the civilian medical force, you apply for a job and that's your job and you stay there. So when I started in Aldershot at the regional rehab unit in 2012, that post isn't available to a military doctor, but had it been, they would have been in it for 2 to 3 years and then they would have moved on. Whereas I started in 2012 and I still work there now. So you do the same or similar job, albeit you're not doing out of hours, you're not doing any of the fancy stuff, you're not deploying abroad, but you're looking after the same people. And you are, in fact, you are providing more continuity of care because you're not constantly moving around. So there are civilian medical practitioners. So they've just changed their names actually to MOD GPs, so Ministry of Defence GPs. So they will work in the armed forces. And then there's civilian consultants, as well as military consultants. And we work alongside each other. But just obviously the military ones have that extra bit that they do as well.
Yeah, what is the rationale behind the 2 year rotation?
So it's a bit different for some places. So, for example, at Stanford Hall, the military consultants won't rotate because they're already at their place of work. That's separate. So, for example, if you're a physiotherapist in the military, you will rotate every 2 to 3 years as part of essentially your rise through the ranks. So there'll be jobs available to second lieutenants, captains, and majors, and you move to gain experience, and you move to on promotion. This 2 to 3 year rotation allows people to do that and move through different jobs. And it means also that some people there are jobs that are great and the jobs that maybe aren't so great, and you don't have to stay in them forever. You can move along. I mean, while I've been at the regional rehab unit in Aldershot, I've been there 12, nearly 13 years, and I tried to count the other day, I've lost track slightly. I've had about 10 or 11 OCs. So that's OC is the officer commanding, so the person in charge of the RRU. So that they have gone through quite rapidly. So often the reason why it's changed so frequently is because some of them came in, got promoted, left immediately. So you see them for 3 months and then they're gone. And that sometimes happens. But yes, so it means that the civilian staff generally stay the same. So there are me and two others who've been at the regional rehab unit since around 2012, 2013. In fact, sorry, four, including two administrators. But the rest have all, it's kind of like come in and rotated around. And so the military staff, you're going to have them there for 2 to 3 years and they'll be gone. And so the team refreshes all the time, which is both a shame and also a good thing. Good for them that they get to move through their career. And as we know, every time you do something new, you gain new experience. Yeah.
Yeah, and then so like the military then. So you've been in it for 20 odd years or so almost, and it's like, well, what's your thoughts on where it's gone, the transition, the changes? What's your thoughts on that?
Do you mean what the military's been up to?
Yeah, just in terms of like for as a person working in the military, whether it be as a serving or as a civilian, like where do you see like the facilities, like they've moved to Stamford Hall, or that, but like where do you
Yeah.
see it? Because the NHS has obviously had major changes I've seen in that time.
So I would say that we are extremely busy. So over the period of time, I'm doing albeit I've now dropped to half the hours that I did originally. Within those half hours, bearing in mind there's another doc now at the RRU doing the other 20 hours, I'm doing I'm not quite doing the same as I was doing in the 40 hours originally, but we have such a massive throughput of patients. We're so busy. So the armed forces are a smaller force, but a much busier force. And so that means, so when you've got people who are on rapid training cycles, what that means is they're either coming back from deployment, they're preparing for deployment, or they're on deployment. And in all of those three phases, they will potentially be getting injured because obviously that involves military training, or they're actually out there doing the job, potentially getting injured, or they come back and then they want to deal with their injuries. And so when you've got a smaller force who are doing more with more potential for injury, those people don't have as much time to rest and recover and get ready again. So if they've had one injury and then they start gathering, like it compresses the number of people who are potentially getting injured for many reasons. It means that certainly in rehabilitation, we're working very hard to maintain that level of activity. And I mean, it would be wonderful to have more people to do that kind of work, but there isn't an endless pot of money. And in fact, when I first joined, we used to have a business manager, and we had another administrator. The business manager's been taken off the RRU, so we've got fewer people doing the work as well. Similar to the armed forces have fewer people, we've got fewer people as well. So we're all more stretched than we were. And I think that there are things that we could do to be more efficient. But the armed forces not dissimilar to the NHS in the way that it can be a little bit slow to react and respond sometimes. But that's not because people are not willing. In fact, it's just like the NHS. The people who work in the NHS, you know, it's almost like you will keep working despite the fact that because you know that somebody's got to do the work. And so we just get busier and busier, and then of course people start getting a little bit overworked and overstressed. And yeah, so that's just kind of what I've seen. I still love the work. I'd have left it if I didn't enjoy it. I love the people that I work with. I like the patient population, people doing a very important job for our country, and also our country doing important work elsewhere around the world, in war zones. And so I see it as an important job and an interesting one. So that's why I'm still there.
Yeah, no, that's really good, and you can see you're still passionate for it. How does it compare for working in the private sector?
I mean, it's completely different. So pure sports medicine actually, um, because our medical director is John Etherington, who's obviously ex-military. So he used to be the defence consultant advisor for rehabilitation, essentially. And he is now the medical director, as I say, for pure sports medicine. So he's very much on board with that multidisciplinary team of its doctors and physios and strength and conditioning coaches and sports tissue therapists all working together, and physiologists to achieve the goals that for our patients. However, the model is slightly different because private insurers won't pay for the stuff that we do in the MOD. So even though we work as a multidisciplinary team in Pure, we don't work in the same room at the same time. Whereas in the MOD, we have what's called a MIAC, which I think John came up with the name, which means multidisciplinary injury assessment clinic. So in that room, there's a minimum of a doctor and a senior physio, and we work in the same room at the same time. So the patient will come in, one of us will take the history, one of us will do the examination, and then they will get an ultrasound scan. They might get an injection, they might get referred for an MRI scan. It's a one-stop shop, and you've got two brains both operating at the same time. And so if I then say, I think that, this is not a doctor problem, this is a physiotherapist, we agree, you don't need injections, you don't need surgery, you need to get strong, you need to potentially have this treatment, that treatment. And then what we can offer in the MOD that is not really available anywhere apart from in elite sports clubs, is we can offer rehabilitation courses, inpatient courses. So where military patients will come to the regional rehab unit for a period of time, for example, 2 weeks, where they will have individual programs, group exercise programs, cardiovascular training, hydrotherapy, manual therapy, uh, pain lectures, anatomy lectures, as a whole piece. And they come in for the 2 weeks so that they can learn about their injury, be supported, understand what they need to do to get better. And then hopefully they go off into the sunset with their own physio, their own regional physio unit, and get better. They're very highly regarded courses. Lots of people say that when they've been on them, they wish they'd done one at the beginning of their career. And yeah, and if only that sort of thing were available, you know, in the NHS or elsewhere for our private patients, because they make a massive difference.
Yeah.
Yeah.
Yeah, no, actually, it is really interesting. You hear so many things like when people they may relate it to elite sport, but also people do cite the military for the way things should be done,
Mm.
multidisciplinary teams, the way it all works together. So how have you seen it? Because pure sports med, forward thinking, John's brilliant, like really interesting guy to listen to, and you've got some really good physio teams there, obviously with Claire as well. So like, what's it been like going into that environment then? And because like you say, it's a very different one to what you'd been working in the military.
Yeah, so I started working there October 22, and yeah, it is different, but it just means you have to work in a slightly different way. So it means that I just need to, you know, communicate better with the physios. I mean, you know, we're literally across the corridor. It's not so I can't talk to them. It's a shame that, and some of them, I was going to say it's a shame that they can't be in the room. That's not actually true. So literally, if they haven't got a patient in and they know that I'm seeing one of their patients, the physio will come in with me, and they will, you know, be there while I'm assessing, and so that they are immediately able to go, okay, I see where we are, and where we need to go. But for the most part, if everyone's busy, that's not available. So then it's about making sure that communication piece that you can then hand over to the physiotherapist. And so yeah, we do work very close together, because of our proximity. And but it's just not quite the same as both being in the same room. It's very powerful to it's powerful for the patient as well, because the way we work is, so in the MIAC, when someone's assessing, so you'll take the history, the other person's typing it down, and then you'll assess the patient. And as you're assessing the patient, so examining them, you will be calling out what you're seeing. And the patient's going, oh, my quads are down, you know, as in I haven't got as much bulk. Oh, they've told me that, you know, I've got reduced range of movement in my hip. Um, you know, so they're listening to the measurements. And so they can see that we're being thorough, but they can also hear that there are differences. And they can hear us obviously discussing things as well. And so I think that there's power in expressing all the changes and the differences that you're seeing, in front of your patient to tell someone else. Um, and Yeah, and the other most amazing thing is that the notes are then written, and you don't have to go back and write a letter. That's probably the most exciting thing about the way the MOD works. But what a time saver! So you've got one person typing and one person assessing, and then so you've got the whole thing smashed out in an hour. Next person. So if in a perfect world, if I was going to say how an insurer, so they would have to pay some money, but they would get their value back if they paid for a multidisciplinary assessment. So you would have your initial assessment with a physio and a doctor. And in that assessment, you will get the opinion of both. And it might cost them a little bit more, that outlay, but and subsequently, they wouldn't have to necessarily go back and forth between the two people having separate appointments and paying separate for each. You would have, you know, whether or not that is something that the private providers have any appetite to do is another matter, and completely, you know, I don't get involved with any kind of that stuff. But in the future, were I to say what would be really powerful to do, it would be something like that, where you can have that one-stop shop, where you see your physio, you see the doc at the same time, you have your ultrasound, and it's all in the one piece. And then you either go, yeah, this is definitely physio, or no, this one needs actually to have doctor-led care and needs to go on and maybe have injections or further imaging, etc., etc.
Yeah, no, it does sound good. Yeah, if you manage to get the insurance people on board, I'm sure that
Yeah.
a lot of clinicians would be very happy with you.
It's an amazing educational thing as well. So, because if you're working in teams, and let's say you've got some junior physios working in the regional rehab unit, they come and sit in, and you learn so much in that environment where you've got more than one person doing stuff. We've got band sixes coming in, so they learn off the band seven and off me, you know, what we're doing. They see the ultrasound scans. Is an amazing teaching environment as well. Um, yeah, I mean, I don't think there's a better model really of care, um, anywhere else. Yeah.
Yeah, I mean, we were talking about that when I was down in Wimbledon and like about the education and getting exposure to things and mentorship and all of that. And it does feel like everyone is really busy, just busy, 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 cracking on with what they're doing, and so much is lost from physios could assist with this and vice versa, and just in general from sports therapists, rehabbers. It does feel like there's quite a lot of siloed working.
Yeah, I would agree with that. And I also think one of the things in sports medicine that's really important as a consultant or any doctor working in sports medicine, my opinion is that you need to know all the stuff the physio knows because you need to know when you are not needed. And so if you can go, so if you've got someone who's come in with shoulder pain and the physio says, it's not better, I don't know what to do with it, and they come in, all you've really got in your toolbox, you've got imaging, you've got injections or surgery, because everything else is basically rehab and strength work, isn't it? And the physio might have said to me, um, they're not getting better. I don't know why. Well, what if the problem is still nothing that needs an injection, nothing that needs imaging or surgery? What if the problem remains a musculoskeletal kind of movement patterning disorder? And so, what I think, well, that was going to be a very big headed statement, but I think I'm good at my job because I've spent so much time with physiotherapists, some extremely talented physiotherapists who are specialists in their field at the RIU. Um, and so I can now do most of the assessments that the physios do. And so I can go, but I can see that you still don't have good control of your shoulder girdle. You definitely don't need an injection. You definitely don't need your neck imaging. This is a movement pattern disorder. The fact that the physio hasn't worked so far is because you're either, well, I don't say this to the patient necessarily, I say the patient's either doing it wrong or they're doing it right, but they haven't done it for long enough, or they've got the wrong exercises that they're doing correctly, or they've got the right exercises that they're doing wrong or not doing at all. It's kind of like that, what's it, Jacob's Ladder or whatever Rumsfeld said, you know what you don't know. Da, da, da. It's the same thing about physio exercises. You've got to do the right ones. You've got to do them in the right way. You've got to do them and you've got to do them for long enough. And unless you do that, you're not going to get better. And that is where the NHS is. The NHS hasn't captured that. So I did an ultrasound clinic this morning for Royal Surrey, and I spend a lot of time thinking if this person doesn't need this injection. I talked someone out of having an injection into their thumb. I nearly talked someone out of having an injection in their thumb. So that was two patients there. And all of the shoulder patients I saw, regardless of what I did to them, they all needed good rehab and better strength. And you just think if only you'd had that at the beginning, we wouldn't be where we are now, which is on your third steroid injection into this particular shoulder joint, because you would have regained your mobility capacity, etc. And so I just think in the NHS, we haven't, you know, yeah, we're just not doing it well enough in terms of you might not see the right physio because it might be a brand new physio, band 5, who hasn't, for whatever reason, because everyone's so busy, is not perhaps getting the mentorship they need. They're not being given enough time to assess the patient properly. They've not got enough time to pass on what they want the patient to do properly. They have to hand out a patient information leaflet. The patient goes on a bit of paper and then they don't do their exercises and then nobody makes any forward progress. All of that, we've paid for that, but nobody's made any progress forwards. And then the patient goes back, their GP says it still hurts. I know, we'll go to the injection clinic and get you an injection. And then you go on the merry-go-round of injections. When if we'd just done the rehab right the first time, so again, you could have a multidisciplinary clinic where you see the physio and the doc. Doc says, no, don't need that. This is rehab. And then you do the rehab well. It could be group classes, it could be individual classes, whatever. But there is so much scope for making the nation fitter, stronger, and healthier just by providing the right activity advice. Um, yeah, but it's so much easier to do an injection, which then wears off, and then they come back. Yeah.
Yeah, no, I think it's interesting. My mum's going through this now, so I'm actually going to play this to her and my dad because I think it is important. Because if you're not used to doing exercises and going to the gym, which that's not their thing, it's so you get a bit confused. I think you do need like walking through it and having not having to go back and forth would be brilliant
Yeah,
if you could do that, where you've got everyone there. This is what we're doing. That's it. Just clarity on it.
yeah. And we don't, we all doctors and physios alike think, oh, well, it's a shoulder problem. They've got to do this particular specific kind of exercise will make them better. But actually, there is benefit to, particularly in some people who perhaps just don't move enough full stop. If you had group exercise classes with generic movement and resistance, they would be able to just build muscle and mobility, build strength, and that would still have an impact, a positive impact on their injury, regardless. So you can get very specific and very individualized care, but actually you can get really good care in a group if you actually get them to do it, which would be, especially for people who, if you're asking a single mum who's got back pain, pelvic pain, 3 children, if you say, right, here's your exercise program, I want you to go away and do this, you might have to go to a gym to do it. It's not going to get done. And these people get failed because they just don't have they're not, their social scenario setting doesn't allow them to do it. Um, and I mean, that comes back to like the social determinants of kind of like ill health and why we as a nation need to be better. People need to have a better standard of living so that they're not worried about their food and education. They have time to worry about their bodies, and they've got money to buy reasonable food, and they've got time to sleep. And if we just did those things a little bit better, we wouldn't have so many musculoskeletal problems. But there you go. I'm off on one of my rants.
No, no, I think it's really interesting because I'm just back from a few days in Ireland. So as well as seeing Phil Glasgow and Kieran Cosgrave, I also went to a couple of clinics where they were doing. I was really interested and pleased to see that they were doing like the clients were over 70 and they were doing S&C work, they were doing rehab. And one in Killarney, like this clinic was really interesting because they had really young people in a CrossFit type class, as well as people getting on for that sort of age. And it was actually like, it was good to see people doing exercises. And I don't know whether that's because it's a town of 15,000, so it's quite small, that I don't know, there's less stigma or whatever it is. But it was good to just see that there's a provision for this, and seems to be seen as being normal.
Well, it probably just takes some people just to say, we can do this. It probably takes personalities. And I think this is where like sport and exercise medicine or BASM and FSCM can make a difference and are trying to make a difference and need to be allowed to make a difference so that we can get into that space and say, this, we want to stop people ending up frail and disabled and with arthritis and inability to move and loss of function. We can't stop that by the time it's happened. But if you go back 20 years, if we get it right now, yes, there's lots we can do for those people, we can help them. But if we stop the next lot of people on that same trajectory to get osteoporosis by getting them moving now, by preventing them to getting sarcopenia, loss of muscle mass, by getting them moving now, there's so much you could do that would then prevent all of that money that then needs to be spent on an ailing, frail population. And so, but you're absolutely right. Getting those 70-year-olds in the gym, that's so important as well. And there's loads they can do. I've just come back from the World Masters with a guy who's 86. Last year he climbed a Munro, and this year he made a lot of mistakes in the forest, unfortunately, but that's because he's running too fast. So this is an 86-year-old orienteer running too fast, and that's why he's making mistakes. And there's no reason why other people shouldn't be able to achieve that. But it's not yes, he's running well now, he's keeping active, but it was probably what he did 20, 30 years ago that allowed him to stay on that trajectory rather than everything falling apart and then trying to put the wheels back on again. Yeah.
Yeah, no, I do think it's interesting. And then I suppose it links into that, just relating from that personal experience from my side, is what are the important non-clinical skills to be an effective clinician?
Oh, well, empathy and communication probably. So you can know loads of stuff, but if you can't communicate it to your patient or get them on board or make them trust you, when I say make them trust you, allow them space to trust you so that they believe in what they're doing and Also, not letting them get away with things. Lots of my patients say, "What do you mean there isn't a quick fix for this?" I say, "No, this is what we're going to do. This is a plan for the next month, for the next year." In fact, I got an email back from a patient the other day who's I'm treating for plantar fasciitis. And she wrote back and said, it was to Pure Sports Medicine. And she said, "I just want to thank Pure Sports Medicine. I am so much better. I have no pain. I'm now able to run 3 times a week. And I just want to thank Dr. Sarah Rollins. I will never forget what she said. She told me I had to do these strength exercises from now and for the rest of my life." And I was like, that's exactly what I tell people. You need to keep strong forever. So yeah, it's trying to not just deal with the now. It's about that piece for the future, and making people realize that they have to move if they want to keep moving. They have to move now. Yeah. So yeah, empathy, communication, caring about your patients, and wanting to see them do better. Yeah.
Yeah. No, well, I think that's a really, really good message. Couldn't agree more with them. So I really appreciate you sharing your time. I'm definitely going to be showing this to both my parents and being like, look, this is they know it, and it's like I think it helps people just talking about it, and the way you communicate it's really good. And if yeah, when you've gone from being very active to then you've found a few ailments, all of a sudden it's like, it's frustrating as well, isn't it? So it's all of that bit that you need to try and master.
Yeah, for sure. And I think, it's around the time of the perimenopause. It's around the time you've talked about people being unwell. So when people have been unwell or have been less active for whatever reason, or they're getting older, you lose muscle mass. And lost when you lose muscle mass, things start to hurt more. And so one of the biggest reasons why things hurt in the perimenopause, it's because in your 40s you've got less growth hormone, suddenly you've got less estrogen around. You also have small kids usually who stop you going from the gym because they're taking up all your time. But in your 40s you tend to have a job that's the most sedentary you've ever had. You're absolutely knackered, you're not getting enough sleep, you're losing muscle mass, suddenly your joints hurt. And we all think, oh, it's because of my hormones. Well, it is a bit of that, but if you don't fix all the other stuff, then if you don't actually move, if you don't do resistance work, it's still going to hurt. And I'm quite passionate about not just offering people HRT and offering people what they need in terms of medical treatments for things, but also making sure that alongside that they understand the most powerful way to get your muscles strong is to put them under resistance. And that goes for men in their 40s. I see a lot of the pure sports medicine patients I have are people who are in desk-based roles, and they start getting problems in their late 30s, and in their late 40s they really start to get problems, whether it's with their knees, their shoulders, their neck, their back. And it's usually because they are just at their most sedentary, because at that time in your 40s all these things come together as a perfect storm. And so that's where we can make the most difference. Yeah.
Yeah. No, no, I think it's a really good message, and yeah, it definitely is because the gym is still a relatively new thing, isn't it? I remember when I was growing up, there was no gyms. It was like the YMCA, and then all of a sudden now they're everywhere. But it's still you still need to get into that habit of it, and it's a lot of it is
Mm.
about superficial look, isn't it? I think for a lot of people,
Yeah.
and it's like really you just want to get in there and be active because as soon as you stop, like it's a slippery slope.
Mm. I mean, I'm very lucky because I work in 2 gyms essentially. So obviously, as you know, Pure Sports Medicine is based in the David Lloyd Gym in Rains Park, which is a great facility. And it means that in my lunch break, I can wander through and I can use the gym. And similarly, the RRU has a gym, and I'm able to use that as well. Um, And so one of the biggest things is actually get people to go out to their gym. In and I think it is easier if you're in a gym, but equally if you can't get one or you don't want to afford one, there's so much you can do on your own. But yes, and I think it's great that there are lots of accessible gyms now that you can access that don't have to cost the earth. And you don't need much kit. You just need some kit and you need to be shown how to use it, and then you're off. And if you can just persuade someone to do something for about 3 months, they should notice the difference. But it takes that long. And the biggest piece I find is to say, can you just give me 3 months, 12 weeks? Because by 12 weeks, if you do your exercises, I can almost guarantee your pain will be either at least half gone or gone.
Yeah, well, I think one of the things like reflect on me, like I'm sports science background, really sporty. When I go in the gym, a lot of the time, I'm just like, what am I doing here? I like to know what I'm doing, and if I don't
Yeah,
have that, so I've recently got someone who's helping me with a plan, and I love it now. I've gone from hating it going in there, but I think if you go in there without any idea of what you're doing, it's a
no,
waste of
absolutely.
time and
And
it's
you just
counterproductive.
wander around. Yeah.
And it's like I hate the gym, whereas now I've gone from hating it to thinking, right, I'm in there and I love it. It's like start the day, get my time in, whether you're listening to something or not, and you're just committing that time to yourself. And it's just good in a number of ways. You just know you've started the day, you feel good because you've done it, and it's really made a big difference on me, even though that I'm sporty, I would say, but it's still having that understanding.
When you have that, I think once you get to the 3 month point, you suddenly realize the impact it's having. At least that then gives you the positive feedback, but it takes that time to get there. And so that's the difficult bit, that first little bit. And I try and persuade everybody to give me that amount of time because, I mean, certainly for myself, I was struggling with some tendinopathy problems in 2020, 21, and that's because I hadn't been able to get properly to a gym, obviously during COVID. Um, and I managed to go from pretty much having pain on walking in both my Achilles insertions to being back running completely pain free within 12 to 16 weeks. And that's just from really regular strength work. But so once you realize that, it's almost like panic if you're thinking, well, I'm a busy on that day, but that I want to go to the gym because I don't want to miss my session because this has such a massive impact on my running. I'm probably running better now than I was in 2021. I'm much stronger. Um, I was getting problems in my hands. I used to have thumb pain in my left hand. I don't know why. I think it's because my grip strength was weaker and I've done upper body strength. I don't have any pain in my fingers anymore. And so, yeah, strength is really important. Exercise is anti-inflammatory. I like a blimmin' stuck record when I'm in clinic, just telling people that they have to go and they have to move and get stronger. But I think for the most part, people take it on board.
Definitely. No, and it's good to see places like Pure Sports Med and the clinics that I've been at and seeing that it's definitely changing. I think the private market has to go that way, and it's good that it seems to be it is doing that. So that's really where I'm passionate about helping those clinics. How do they help them make that step to push on from being a physio but having in a gym, different things like that. So yeah, I think it's a really exciting place. So no, but I really appreciate your time sharing your insights. I think we'll come back to this because I think there's more orienteering and there's more around the sort of health and strengthening side as well.
Yeah, yeah, yeah. We haven't even talked about ultrasound or women's health or all the other stuff that I get up
We'll
to.
we'll do those ones in person. So I'm doing some of those ones in there. So no, but that's it. Yeah, that's it. You've got a real interesting thing, and it's great to see your passion about the things that you're involved in. So yeah, I will. Thank you for sharing. I look forward to seeing you soon.
Yeah, pleasure, pleasure. Nice to see you again.
Thanks, Sarah.